Well, good afternoon, everybody. Thank you for coming. We have a virtual room, but it's pretty full. I count over 50 people here. Welcome to what I believe to be the 23rd edition of the Razin Prize for the best paper by a graduate student at Georgetown University. This is a prize that was started in memory of Razin, who was a PhD student and passed away while he was a PhD student here at Georgetown. And every year we do this. This year we do it in a different way, but by the look of it, just as successful. I will ask Martin Ravalian in a minute to introduce our host, because this is a Razin economic policy lecture, and we're very lucky to have an extremely distinguished speaker from Princeton University. Janet Curry is the Henry Putnam Professor of Economics and Public Affairs at the Woodrow Wilson School. The proceedings will be as we normally have them. Martin will introduce the speaker, then Janet, of course, will take center stage. Then there'll be a Q&A session. I'll say something about that in a second, and then we will present the prize to Francisco Garrido, who's this year's winner, with advisors John Rust and Nate Miller. So this is not your normal Zoom meeting. It's a webinar. That means that the questions you should be asked using the Q&A function that you should have on your screen when the Q&A session starts. And then I will do my best to let you know, again, in that window, that you will soon be given the audio line in order to ask your question, so that you're not caught by surprise. The participants will not appear on the screen. They will be able to ask their questions on using the audio, and then Janet will, of course, have a chance to answer the questions. So thank you all very, very much for coming. I want to do one last check to see if Asaf Razin has been able to join us. He is not. The reason is simple. He's in Tel Aviv, so it's very late at night. But we are recording this. He has asked us to, and hopefully he'll be able to see this tomorrow. Without further ado, please, Martin, introduce our very distinguished speaker. And thank you, Janet. Thank you, Martin. Thank everybody who has helped us organize this. It's actually a little trickier than it looks. So let's hope it all goes well.
Okay. Thanks very much.
Precisely my point.
Yes, proven. QED, thank you very much, Luca, and thank you very much, Janet, for agreeing to do this. I was personally very pleased, and I think the whole department was very pleased when you accepted our invitation. Introduction, Professor Janet Curry originates from Canada, which I hadn't actually realized. Did her undergraduate and early graduate studies at the University of Toronto, and did her PhD at Princeton. She's also taught at Columbia, UCLA, and MIT. Amongst many roles in the profession, she co-directs the program on families and children at the NBER, and as well as being co-director of the Center for Health and Wellbeing at Princeton. Many awards. I was really one notable one at the World Economic Forum named Janet one of the top 10 women in economics. She's also received the Carolyn Shaw Bell Award from the American Economics Association in recognition of her mentoring of younger economists. I know Janet's work from way back, and I guess the primary focus, it's really the health and well-being of children, and really putting children at the center stage of that, and looking at their welfare both in the short term and over the whole life cycle, looking at it from their point of view. And also closely linked to that, a real focus on policy, evaluation of policy, implications of her research for policy, and a range of programs. I think she's looked at Medicaid, public housing, food and nutrition programs. I really liked her work on the Head Start program. I've referred to it often, looking at the effects on kids and their siblings, looking at effects on their test scores and longer term measures of attainment. A host of work also on the determinants of fetal and child health, and lots of interesting stuff on the role of healthcare, obviously, but nutrition, pollution measures, how it affects kids and how it affects their development, maternal education, smoking behaviors of parents. I think probably as much or more than anybody, I think Janet has highlighted the importance of early childhood development. And this is something you think about today, we always take it as given. We've got governments and politicians all over the world conscious of this issue and the importance in many respects, including the productive capacity of an economy and its evolution, let alone the direct welfare of kids and so on. And I think the entire world owes a debt to Janet for the research she's done and the influence it has had. So without further ado, again, we're really happy to have Janet Curry giving this lecture. Her topic today is child mental health as human capital. Thank you very much, Janet. Over to you.
Hey, thank you, Martin. That was a very kind and effusive introduction, so I hope the talk merits it. I'm going to share my screen without further ado and get started. So I'm going to be talking today about child mental health as a form of human capital and trying to emphasize its importance. So as we know, mental health is a form of wealth that's embodied in people. Historically, the economics literature on human capital has really focused on education, and child health was thought to affect well-being primarily through that channel by impacting education. But increasingly, child health has been recognized as an important form of capital in its own right. I guess the worldwide pandemic is really emphasizing that. And mental health is receiving increasing attention as part of that. So one reason why mental health is getting more attention is just because it is really important in the workforce. I don't have a lot of time to go into that, so I just pulled out some examples. This graph is showing data from the US General Social Survey, where they ask a question, which is written at the bottom of the screen there. Now, thinking about your mental health, which includes stress, depression, and problems with emotion, for how many days during the past 30 days was your mental health not good? So this question was asked to employed workers. And the remarkable thing is how many people are self-reporting a very high number of days in the last month where their mental health was not good. Okay, so this is a self-reported measure. Maybe you prefer to look at something a little bit more objective. One thing that you can look at is emergency room visits. So in this table, what I'm doing is just taking all of the emergency room visits for 6 large US states from the Healthcare Utilization Project data. And in 1,000 people, normally in a year, you'd have about 380 ER visits. And of those 380 visits, about 51 would have some sort of mental health issue involved. And I think when I tell that to people, they often think, well, that's all substance abuse. And there is a chunk, which is substance abuse, but the largest components of that are actually mood disorders and anxiety disorders. So we have a lot of people showing up to emergency rooms with some sort of mental health condition every year. So how do we think about this as economists? The usual framework that we have has people investing in child human capital, and specifically parents are assumed to maximize their utility by choosing these investments along with other things that increase their utility. So here the parents' utility depends on child health, age, and their own consumption. They face a budget constraint for all the things that go into their own consumption and these investments. And they also face a production function, which is at the top line there. And here, this is a constant elasticity of substitution production function with 2 periods. So you can invest in period 1, you can invest in period 2, but there's also these exogenous shocks that happen, that might happen in period 1, might happen in period 2, that's going to affect the productivity of your investment. So in this framework, you could think of period 1 investments and period 2 investments as being perfectly substitutable. So it could be that if something bad happens to you when you're a kid, you can put more money into the child when they're older and kind of fix that. Or it could be that investments in early periods and investments in later periods are complements, in which case the investment that you've made in the child in the first period is going to have an impact on what you can do in the second period. So a key point out of all of this is that the effects of childhood events don't necessarily depreciate over time. They could actually grow over time, or perhaps even emerge above some threshold at a later point. And that seems like a good way to think about mental health problems, because we know that there's a lot of mental health problems that basically first show up or are first noticeable in adolescence. So even though the roots of the problem might be in early childhood and there might have been indications in early childhood, often it really becomes a problem in adolescence. And these mental health problems are very common in adolescence. So about 22% of US adolescents are estimated to have ever suffered a serious health impairment. And that's a sort of similar rate as among adults. And mental health is one of the most important determinants of adult outcomes, especially because it affects people's ability to work. If you want to look at causes of days lost, mental health is right up there. And if people lose days because of mental health conditions, they're likely to be out for a longer period of time than for a lot of physical health conditions. Now, this emphasis on mental health is not that new in the sense that economists have been talking about it for a long time, except that they, like to my mind, are using euphemisms. So instead of talking about people's mental health, which maybe makes people uncomfortable, we like to talk about their non-cognitive skills. Okay, so this figure is from a nice paper by Heckman, Stixrud, and Aizawa, where they're using data from the NLSY to simulate the effects of cognitive and non-cognitive skills on people's wages. And so the point of this surface, if you follow along the non-cognitive skills, is that somebody who has not very good cognitive skills, but great non-cognitive skills in this simulation actually does better than somebody who has great cognitive skills, but not so good non-cognitive skills. Right? So that's a sort of interesting thing to think about when you're thinking about trading off. Obviously, it's better to have great skills on both dimensions, but non-cognitive skills are very important. To talk about this sort of mapping between non-cognitive skills and mental health, I want to turn to another paper, this one by Per Anders Eden, which is looking at the return in the labor market to non-cognitive skills using Swedish administrative registry data. So they're more specific about what they mean by non-cognitive skills, but that includes social maturity, focus, internal motivation, and stress tolerance. And each of those concepts actually maps into a common mental health condition. In the sense, social maturity would be affected by something like autism spectrum disorder. Focus is kind of what ADHD is all about. If you're depressed, you don't have internal motivation. And if you have problems with stress tolerance, that's similar to having anxiety disorders, right? So there's a very, not very clear border between what we've been talking about in terms of non-cognitive skills and these other mental health constructs. Okay, so talking about the effect of mental health on labor markets, I want to show you an example, which is using Canadian data, which is administrative data where it was possible to link medical records to educational records and also social assistance records. So in the sample, which was from the Canadian province of Manitoba, a relatively small province, we had data on 50,000 children, and we set out to compare the impact of mental health conditions, and the most common ones in this data were ADHD and conduct disorders, with the most common physical health conditions, which were asthma and injuries. We looked at 4 different ages, and we also did some work looking at the persistence of various conditions. So this figure is just summarizing kind of the main takeaway. In this case, we're looking at the probability that somebody received social assistance after age 18. And you can see that having ADHD or a conduct disorder at any of these ages had a larger effect than the 2 physical health conditions that we're tracking. Similarly, in this province, there's a certain set of courses that you have to take in order to get into college. And so the probability that you took the math courses that you needed to take to go to college is much lower if you're suffering from ADHD or conduct disorders than if you're suffering from some of these physical health conditions. Now, these mental health conditions, as I said, may have their roots very early in childhood and even in the prenatal period. And there's relatively strong evidence, I would say, linking the prenatal period to certain mental health disorders. One reason why the evidence is stronger for the prenatal period is it's a very well-defined period. So you can find a cohort that was affected by something in utero, and then you can track that cohort. So that's exactly what was done in all these studies of the Dutch hunger winter, which was the period of time during the Second World War when there was famine in the Netherlands because of a Nazi blockade. People were reduced to eating tulip bulbs. So children who were in utero during that period of time were more likely than cohorts just before or just after to have schizophrenia. Okay. That's a very serious mental health condition. On a somewhat less dire note, other people have looked at the Danish registry data, looking at Danish twins, and showing that there's a very strong correlation between birth weight, which is obviously determined, by the time you're born, and ADHD, even in identical twins. Another very nice contribution to this literature is by Petra Pearson and Maya Rosen-Slater, where they look at Swedish registry data and they compare basically mothers who suffered the death of a close relative during the pregnancy to mothers who suffered the same thing just after the pregnancy. So the comparison here, all the families had a loss, but some of the families had a loss during the pregnancy and some afterwards. And the ones who suffered the loss during the pregnancy, the children have a higher probability of using an ADHD drug compared to the comparison group. And they also have a probability of using drugs for anxiety or depression in adulthood, which is significantly higher. So the idea here is to look at stress during pregnancy and what effect that might have on future outcomes. Okay, so these are sort of negative results in the sense that we're showing that it's possible to harm people in utero, and that can have long-lasting measurable effects, at least at the cohort level. We can also show that there's some interventions that seem to have had positive effects on cohort level mental health. So Sarah Miller and Laura Weary have papers looking at the rollout of Medicaid coverage. So Medicaid is the health insurance program for low-income women and children. It was greatly expanded during the 1990s. The expansion took place at different times in different states, so you can use that variation to see the effects. And what they find is that the children who were affected prenatally have lower indicators of mental distress when they're measured many years later. In some work with Anna Chorney, we've looked at prenatal participation in a program called the WIC, which is the Supplemental Feeding Program for Women, Infants, and Children. So it's a nutrition program, but it's strongly linked to medical care because it's often delivered in clinics, and it's supposed to help facilitate people's access to medical care. So you can think of it as a bundle of nutrition and medical services. We followed children who were born between 2004 and 2009 and can be followed up to 2015 in Medicaid data. And what we find is that if we compare siblings, children who were covered by WIC were less likely to have ADHD and less likely to have other common childhood mental health conditions than their siblings who were not covered by WIC. These effects are greater for African Americans, and that may be because they're more likely to be low income and affected by the program. Okay, so I have been arguing that improved access to things like health insurance and nutrition programs has a positive effect on cohort level mental health. But we hear all the time that child mental health is actually getting worse and that caseloads for things like ADHD are rising and so on. So that I think it's a little counterintuitive to argue that things are getting better. So why is that? One reason is because diagnostic standards for many conditions are changing. And also the changes in the way health insurance is delivered and the probability that children get screened can also have big impacts on the number of kids that get diagnosed. So basically, what I've written at the bottom here is if you have more access, people go to the doctor, they get screened, then you're going to find more cases. So a big part of this increasing caseload could be due to that. Okay. So one sort of indicator of that is that if you look nationally, this is data from the Medical Expenditure Panel Survey in the US, you see over this period of time here, I'm sorry, oh, my mouse is a little bit sensitive. There we go. You see increasing numbers of kids being treated for ADHD. That seems to be mainly driven by what's going on in the Medicaid program. And in the private health insurance population, the rate is either flat or even declining over this period. Okay, so that's kind of surprising. And you might ask, well, what is it that was going on with the Medicaid program that might have caused more people to be screened and diagnosed? Well, the big thing that happened was a change from fee-for-service to managed care within Medicaid. So these managed care plans have incentives to promote screening because they get a capitated reimbursement rate for each person. So they get a payment per head, and the payment is bigger if the child has a chronic condition. Okay, so they really have an incentive to go out and find chronic conditions. they also get penalized if they're doing worse than their comparison group of other care plans in terms of doing these screenings. So there's both a carrot and a stick. Okay, so South Carolina switched their default plan to managed care in a somewhat staggered way. And we look at the effect of that in two different ways. One is an event study where we're looking at all children sampled in the 2 years before and after the switch. And the second thing we can do is we can actually look at the same child and say, okay, you have this child who's living in a place, they're covered by Medicaid fee-for-service. Now we change their plan to managed care. What happens to that child? Okay, so looking at the event study, you can see on the top that the well child screenings rise following the switch to managed care. And these are all kids who had Medicaid, so they're all entitled to these services. The question is, are they getting the services that they're supposed to be getting? And so that goes up. And then very parallel to that, the number of kids who are being treated for ADHD goes up at the same time. Okay? So the kids get, or they're more likely to get seen, then they're more likely to get diagnosed with ADHD. Now, I think a lot of people think, well, that's probably a bad thing. They're probably overdiagnosing these kids with ADHD. But when we look at the same child results, the fixed effects results, we see that children are more likely to be getting well child visits. They're more likely to be getting developmental screenings. They're quite a bit more likely to be getting vaccinations, and they're even more likely to be getting visits if they're sick. Okay, so that doesn't sound so bad. And then putting these increases in diagnosis in context, we see, yes, they're more likely to get diagnosed with ADHD. They're more likely to get diagnosed with depression. They're also more likely to get diagnosed with asthma, or ear, nose, and throat problems, autoimmune conditions. And we even see an increase in getting diagnosed with mild infections, which is interesting because the capitated payments that they got did not increase with mild infections. Okay, so that seems to be purely an effect of being seen more. Okay, so the form of insurance can really matter in terms of whether people are getting seen, and you should expect that if more people get seen, you're going to see more treatment. Okay, so I've touched a little bit on prevention through programs on the role of diagnosis in driving some of these increasing rates. And now I want to spend the rest of the time talking a little bit about treatment. You know, what can we do about these mental health conditions? And there's huge variation basically in how people get treated for mental health conditions across the US, which is a little frightening, but also presents a research opportunity in that you can maybe see what a difference these variations make. There's also a lot more administrative data starting to be available on health outcomes, whether it's from hospital discharge data sets or administrative claims data. Okay, so this figure is drawn using data from a company that's called IQVIA, which collects data on retail prescriptions for the whole US. So each little square here is a county, and what we're computing is just the number of prescriptions for antidepressants per 1,000 persons 10 to 19 years old in 2014, okay? So the darkest red here is actually 967 prescriptions per 1,000. Now, these are 30-day prescriptions. So, you know, that's just saying that, you know, some of the people are going to get 12 per year. So you could divide the 967 number by 12 maybe. But that's still an awful lot of prescriptions. And then the places with the lowest prescription rates are, you know, which is much of the graph, are having rates from 1 to 74 prescriptions per 1,000, which seems much more reasonable. Okay, so I'm going to talk about some work that I'm doing currently with Emily Cuddy, who's a graduate student at Princeton, looking at treatment of mental illness in the US. I've already hinted that there's a lot of variation. So the question fundamentally that we're going to be asking is, well, would things be better if there was less discretion and more rules in terms of how people get treated? So hopefully I've already motivated you a little bit to think that this is an interesting question. We know that that mental health conditions often start in adolescence, that these kinds of disorders can be very debilitating in terms of future outcomes. But there's actually very little information available on how adolescents are treated, why they're treated differently, and what is the consequence of variation in treatment. So what we're going to do is look at data from a large insurer, Blue Cross Blue Shield, and look at children who are treated between 2012 and 2018. So this is definitely a large data set, and we have a lot of variables that could possibly be useful to predict whether or how somebody gets treated. And so we use Lasso to try to boil that set of variables down. And then we look at the effects of how they got treated on their medical utilization over the next 2 years. So we're going to focus on the first time the child got treated. And the reason for that is because there's a lot more clarity about what you should do if it's the first time. If somebody's already being treated, even if you took over their care, you might not agree with what was done before, but you also might not want to change it suddenly, right? So you could get locked into a particular path. So the first time that a child is seen, there seems to be fairly broad consensus that it would be appropriate to try therapy before you prescribe drugs. Or if you feel you must prescribe drugs, they should at least have therapy in addition to that. Also, it seems reasonable that clinicians should start with a drug that's been approved for use in children. So when I say an FDA approved drug, I don't mean that it's necessarily for their specific condition. I just mean that it's FDA approved to be used in children at all. Okay, so that seems like a pretty minimal criteria. And then there's drugs that you would really hope that clinicians would avoid. There are, the standard of care these days is that you're treated with SSRIs, selective serotonin reuptake inhibitors, which have less side effects than older tricyclic antidepressant drugs. Also, tricyclic antidepressant drugs have not been shown to be effective in adolescents. You think you might want to avoid addictive drugs and drugs that are dangerous if you take them in overdose. So a drug that is both addictive and dangerous in overdose is benzodiazepine. And so you probably want to avoid those, at least for the first time that you're treating somebody. Okay, so the sample here is going to be children 10 to 17. And as I said, we're going to follow them for 24 months. We end up with about 97,000 people. And the majority of them are 10 to 14 years old when they have a first mental health episode. So what do I mean by an episode? We define episodes using diagnosis codes, procedure codes, and drug prescriptions. The reason for that is because there's a lot of kids in the data who are receiving therapy or psychiatric medications, but don't have a diagnosis code, at least initially. And so we also do things excluding the children without diagnosis codes with very similar results. So we can compare these children who had a mental health episode to the broader sample of Blue Cross Blue Shield children who meet similar sample inclusion criteria. And then if we do that, we get that 9.2% of the children in our sample had a first spell. That's sort of comparable with the data that you would get from the CDC about the number of children who are being diagnosed with things like anxiety or depression. And just comparing the full sample of Blue Cross Blue Shield children to this mental health sample. That's what this red box is trying to do. You can see that the children with mental health conditions are a little bit more likely to be female. They're a little bit older when they first appear in the sample, but most of these kids are first appearing to us between age 7 and 8. So then we're following them up to the time they have their first spell. They tend to be higher cost. They're more likely to be hospitalized. They're more likely to be using the ER. The monthly cost is double. They're also more likely to have what we call a neurodevelopmental condition. So that would be something like ADHD or autism, which people normally are diagnosed with much earlier in life. And in some sense aren't really an illness in that like they're a condition that you're going to have the rest of your life. There's not a cure for them. Okay. We also see that just looking at this mental health condition, the average age at the first episode is 12. So hold in your mind, we're treating 12-year-olds here. Some of them first show up by being hospitalized. Some of them show up in the ER, but most of them are showing up having an evaluation the first time. Highlighting a few other things here, looking at how these kids get treated or don't get treated. Actually, after a first episode, only about 3/4 of them get treated within 3 months, which is what we're using here as the treated variable. About 43% of them have therapy only. Not very many of them get therapy and drugs. A lot of people get drugs only. And then this last column here is emphasizing kids who got drugs, and they were one of these things which we think they shouldn't have got, at least the first time out. So a drug that's not FDA approved for use in children at all, a tricyclic antidepressant, or benzodiazepines. Okay, so that's a pretty large percentage of them that are getting that. And you could also see, and this is going to foreshadow our results, that the kids who get therapy only have relatively low costs, the kids who get drugs have higher costs, and the kids who get these red flag drugs have the highest costs. Now, that could be because they're sicker, right? So I haven't proven anything, but I'm just showing that that's what the correlation is. Looking at, well, what did these kids have? Most of them have a mood disorder or an anxiety or stress disorder. And then, as I mentioned, there's a fairly large chunk that don't have a formal diagnosis, even though they're being prescribed drugs or therapy. Okay, so as potential instruments, what we're going to think about is the supply of different kinds of providers in their area of residence. And in these kinds of papers, there's different approaches to defining what a market is. Sometimes people just draw a circle. Sometimes people use what's called a health service area, which is an area about the size of 3 counties. What we decided to do was to define the market using where people in that location go to get care. Okay, so this map is a map of Princeton, New Jersey. That's the dark blue. And then the light blue places are all the other places where people in Princeton, New Jersey go to get care. So we consider those to be part of the market. There's also a little bit here in Philadelphia. Okay, so this has advantages and disadvantages. One advantage is that the same place could be in the market area for more than one zip code. We can also control for the zip code level fixed effects, which we'll do. Okay, so these models have lots of variables, so I've sort of broken them into parts, and I mainly want to focus just for this talk on the determinants of red flag drug use. So you can see that older children and girls are more likely to get these red flag drugs. Children whose first claim is in a hospital are actually more likely to be getting these drugs. Children who had an evaluation, which may be a good indicator of better quality care, right? They actually did an evaluation before they started prescribing you all these treatments, are less likely to be getting these red flag drugs. Looking at the effects of these supply variables, there's some effects of red flag drugs, but what I wanted to highlight with these boxes are essentially that places that have a lot of psychiatrists give out a lot of drugs. You have a lot of people getting drug-only treatment in places that have relatively more psychiatrists, holding the number of therapists constant. And places that have more therapists are less likely to have drug-only treatment. And then when you look at therapy, it's the reverse. If you have a lot of psychiatrists, then you're less likely to get therapy only. If you have a lot of therapists, you're more likely to get therapy only, right? So these supply side variables do have effects in the way that you might expect on the types of treatments that people get. Okay, so we want to actually instrument for the type of treatment because there's a lot of biases that you could think about in OLS estimates. For example, you know, if the higher cost people are the ones who are more likely to get more intensive treatments, then you might even find that treatment was associated with, you know, more costs or more sickness. So we use Lasso to select the variables that are most predictive of the treatment outcomes. And then we use those predictions as instruments. Okay, so we're just trying to summarize a lot of variables by using Lasso. Okay, so we use the procedure described in Bellini et al. That has a data-driven penalty. We require that Lasso selects some of the variables, so they have to select, it has to select the demographics, the zip code fixed effects, and then it has a choice about how to deal with all these possible supply side variables. So we have up to a third degree polynomial in the supply side instruments, and we interact them with all of the demographics. So the outcomes that we're going to look at are first spending, which is a natural enough way to summarize impacts on care. But we also look at whether patients went to emergency rooms and whether they were hospitalized, which are two, you know, very salient outcomes. And we look at the effects of a particular treatment at 3 months afterwards, 12 months afterwards, and 24 months afterwards. So focusing here on the two-stage least squares results using the Lasso selected instruments. Oops, I think I just skipped. Yes. The first thing that we look at is the effect of having any treatment. I think I skipped over to, there we go, on spending. Okay, so you know, a lot of times people say, you know, well, if you get the right treatment, that will reduce cost. And that's a hope, but it doesn't seem to be the case here. I think it's more realistic. A lot of times, you know, if you treat people, then you incur costs, and so you're going to have higher costs. So you can see that that's true here. Total costs go up, both the mental health specific costs and the overall costs. If we look at the other issues, whether they used a facility at all, so this is mainly driven by ER use, you see that the kids who are treated are actually more likely to be going to ERs, and they also have more nights in the hospital, and that tends to grow over time. So that's looking at whether you got any treatment at all. Conditional on getting some treatment, you can say, well, did they get drug treatment or not? Right? So if they got drug treatment, that is associated with higher total costs, again, both for mental health and overall. You also see that facility use starts out being higher for the people with drug treatment in the first 3 months, but then actually is not significantly different. And there's also not a significant effect on number of nights in the hospital, although it starts to turn negative by the end of 2 years. And then the third thing we can look at is, well, what's the effect of getting one of these red flag drugs conditional on having any drug treatment? And that seems to, interestingly enough, lower the mental health costs, but increase overall costs. And I interpret this as side effects, essentially. So people end up going to the emergency room because taking one of these drugs carries a higher risk of side effects, and then they incur medical treatment for those side effects. Also, looking at the effect of red flag drugs on facility use, you see an increase in use of the emergency rooms and not a significant effect on number of nights in the hospital. So it's a little bit difficult to put all of this together. And so I think it's easier to think about it in terms of a sort of flow chart. So, you know, first of all, the question is, do I get treated or not within 3 months? If I don't get treated, our estimates imply that the cost is about $3,500. If I do get treated, I have higher cost. Okay. But if I do get treated, then I may be treated with drugs or not. If I don't get drugs, my cost is about $3,400. If I do get treated with drugs, my cost is actually a lot higher. And if I get treated with red flag drugs, then my cost is, you know, the highest of all, right? So there I'm having a cost of $9,653. And so you could compare that to the cost of being treated only with therapy, which would be up here, which would be $3,415. So there's some really big differences in cost associated with these different regimes. There's also differences in facility use. So here, if I look at the effect of getting drug treatment, but not a red flag drug, my probability of using the facility is 0.21. But if I used, or if I was prescribed a red flag drug, then my probability of using a facility is 0.36. Okay, so that's quite a bit higher. And similarly, if I look at the same thing, controlling for diagnoses. So the ones I just showed you were not controlling for diagnosis. I get a much starker split. Okay, so here, if I got drug treatment, but I was not getting one of these red flag drugs, the cost is $2,334. But if I got one of these red flag drugs, then the cost would be $13,270. Okay, so I guess going into this, I kind of was very negative about drug treatment and was thinking, well, you know, this would be about whether you got therapy or whether you got drug treatment. And now I'm thinking this is much more about what type of drug treatment are you getting? And are you getting one of these drug treatments that seem really inappropriate for a 12-year-old who's having their first mental health episode? Similarly, the probability of using a facility is pretty low if you're using kind of a reasonable drug regime. And if you're using one of these red flag drugs, it's much, much higher. That's like an order of magnitude higher. And so the conclusion then is that there's a lot of very questionable prescribing going on to these children who are suffering a first mental health episode. Having Any treatment in the first 3 months after an initial episode increases the cost and the facility use. Conditional on any treatment, drug treatment is higher cost, but that seems to be entirely driven by these red flag drug treatments. And so what this suggests is that adherence, even to kind of the loose guidelines that are out there, would actually have a significant effect on costs and outcomes for these children. So just a sort of overall summary is, I hope I've convinced you that mental health is one of the most important aspects of child health. It has larger effects than many common physical health problems in terms of children's future trajectories. And so there's really an urgent need to better understand the determinants of treatment and how to promote good treatment for these children and hopefully better outcomes in the future. So I will stop there and happy to take questions.
Thank you very, very much. And I'm beginning to see, well, Eric Levinson can ask his own question. Let me repeat for the attendees, for the participants who are not on the panel, the way this works. You have a Q&A button at the bottom of your screen that will open a box that you can type your question, and then from the panel, we'll give you a heads up that you're going to be able to ask your question before we give you the audio line. So only the people who are on the panel, quote unquote, will be able to be on the video as well. And to get the ball rolling, I can see that Eric Levinson has a question to ask, and he can unmute himself and just do it.
Thanks. Hi, Janet. The first figure you showed and the map were very intriguing because they showed two things. One is that mental health adverse outcomes vary pro-cyclically, or count. Yeah.
Sorry, I just want to go back to the figure. Sorry to give everybody whiplash.
So that one, second one.
This one, yeah.
So it looks like it's business cycles. And the second, maybe with some delay. And then you showed this map that looked like a Dartmouth Health map of counties across the nation. In some counties, there were 900 prescriptions per 1,000, and some close to 0. And so there's this variation across time and across geographies. People must have looked at other health outcomes, not mental health, but asthma or diabetes or other things. They also vary across time and across counties. And I wonder if this is similar.
Yeah, so the reason I wanted to go back to this figure was because when I looked at it, I thought it wasn't very pro-cyclical. Like clearly there's some variance in that top line about any, but if you look at the recession in 2008, you don't really see like a huge downturn. And that's similar to some of Angus Deaton's work looking at responses about well-being when you ask people about their life satisfaction and so on. You didn't really see huge nosedives with the recession as you might expect. So there is literature talking about the cyclicality of mental health, and obviously right at the moment we're having lots of discussion about the negative mental health consequences of COVID. Some of that may be just the isolation and the lockdowns and fear of contagion and so on, rather than the economic effect per se. So I'm not so sure that I would take that away from this figure. On the second thing, how correlated are patterns in mental health and patterns in physical health? That is a good question. I know that for adults, you know, the same places tend to have people who have all kinds of, you know, clusters of problems. I'm not so sure whether that's true for children. So I should look into it and find out.
Thank you.
So there's another question that came in from Garance, and with the sort of the back shock here, not sure how, whatever is easier for Garance to be able to ask her question, put them on the panel, give it the audio line. I don't think.
I think you unmuted me, so I can ask a question. And sorry, we had another seminar speaker, so I came a little bit late, but in terms of outcome, I was a bit surprised by mainly looking at the cost and then I guess entering facilities. Like, so how do we know that what can we tell about the drugs versus the therapy, for instance? Like, I can think about both outcome for the kids, like are they feeling better? How can we compare like number of episodes that they have, or something about acuity, or even worrying about the tail events like suicides and other, how do we know? I understand the cost part, but I understand less, how do I judge whether kids are doing better or worse? Or...
Yeah, so those are really good questions. I'm using claims data, right? So a claim is generated by a medical provider when they make a bill. And
Yes.
so on the bill, they have to say, what was wrong with you? What did they do? And how much did they charge? So that's what you've got to work with in this data. So the benefit of using claims data is that you can get a sample of 97,000 people. You know, even narrowly defined, looking at people who have a mental health episode and so on. The cost is that I don't have survey data, you know, on how they felt and whether they had suicidal ideation and so on. And indeed, the claims data isn't as great as you might think as well, because a lot of people are missing even a diagnosis, right? So in terms of the outcomes that I chose to focus on, in addition to cost, which is sort of a natural thing, I suppose, for economists to look at, and something where you can add up everything, some value of everything that they got. I think the facility use is actually a good thing to look at. And in some ways better than suicide, in the sense that like suicide is thankfully very rare. So it's quite hard to do empirical work on suicide sort of at the local level, just because there aren't a lot of suicides. There are many more, as I showed you at the beginning, emergency room visits. And emergency room visits are what happens if you have a mental health problem. Like if you just took a random psychiatrist and phoned them up, you would get a recording, and the recording would say, if you are having a mental health crisis, go to your nearest emergency room. That's what people are told to do, right? So it's not an accident that you see a lot of people showing up with mental health problems in emergency rooms, because that's our sort of first line response in this country. So seeing that people who are treated in one way rather than another are more likely to be showing up in the emergency room, I think is an indicator that the treatment isn't very good for them. Similarly with hospitals, like hospital stays are even more disruptive, you know. So if you are suicidal and you show up in a hospital or in the emergency room and they think you're not safe to be on your own, they'll put you in the hospital, right? So those are the outcomes that I'm measuring, is whether you showed up at the ER and whether you got put in the hospital. Right?
And for those red drugs, do you worry that those are experimental drugs that they give with the cases that are really bad? Like, or are we thinking it's a mistake to give those drugs? Or do we think about it as, I have that 12-year-old that, you know, whatever I've tried has not worked. Now I'm going to try some experimental drug on them?
Right, so that's why I'm looking at the first time. Okay, so what you should think of is you're bringing your 12-year-old who's never before, you know, had a mental health problem that sort of rose to the level of being treated. You're bringing them for the first time, and they're prescribing to you, you know, a drug that's not even approved for children, when there are many other drugs that are approved for children.
Okay.
Or they're giving you a benzodiazepine, which is an addictive drug, right? Or they're giving you an older tricyclic antidepressant. So tricyclic antidepressants, the reason why antidepressant use really took off when SSRIs were invented was because they had so many less side effects than the tricyclic antidepressants. So, you know, you wouldn't even, with an adult, you wouldn't start with a tricyclic antidepressant because they cause lots of weight gain, they cause heart problems, they could cause your blood sugar to get all screwed up, they could cause lots of problems. And there's this whole other class of drugs that are available. So yes, I think it's a mistake. You know, presumably doctors don't, you know, it's not like, it's unlikely to be financially motivated because they're not making more money by prescribing one thing rather than another thing, particularly when it's one of these old drugs, but they're doing it anyway, right? So presumably they don't know any better and nobody's paying any attention and nobody's telling them they can't do that.
Thank you so much.
I think Martin Ravalian has a question. You need to.
Okay. Yes, I've done. Thanks, Janet. That was very interesting. I guess a comment and a question. The comment is it's surprising to me that it sort of sounds like you're talking about a developing country. India, we've had so many examples of this misdiagnosis and this crazy drugs. And the red flag drugs seem to be very common. The work of Jishnu Das here at Georgetown, and this is Canada.
No, the U.S.
Oh, U.S. Oh well, okay. Maybe I shouldn't be so surprised. Like I somehow missed that detail, but I am still surprised. But okay, it's quite revealing and important. Just one question. You know, this is an instrumental variables estimator, and alas, we have this. We've moved a long way with instrumental variables estimators, and we spend a lot more time than you did on justifying the instrumental variables estimator. You talked a lot about the first stage, and I've given your methodology, I'd really expect a strong first stage. I think that's very likely. It's the old exclusion restriction. And I'm not questioning it, I just had a very hard time evaluating it. You didn't tell us enough. And I'm conceptually thinking, what are the arguments against this, for or against this exclusion restriction, which is obviously crucial, but I couldn't evaluate it. Any further comments on that would be good, I think, especially for our PhD students watching.
Sure, that's a great question. In the literature, what is suggested as being one of the main reasons why people get different kinds of treatment is basically supply effects of different types of providers. And so, you know, one thing that may be important as well, are there a lot of psychiatrists who treat children in your area? Or, you know, there's a lot of areas that don't have any psychiatrists, so maybe your primary care physician is going to end up treating this. And maybe your primary care physician got 1 week on this in medical school, you know, 30 years ago. And so that could clearly have an impact. Therapy, you know, do you have lots of therapists in your area or not? So So the general idea is that those things are going to be related to the types of treatment that people got. So essentially, I'm trying to use what's available in your area as an instrument for what you got. Now, if you just throw all of those things into the first stage, you'd end up with a bunch of weak instruments. And we know that there's lots of problems with doing that. And so what I'm trying to do essentially with the lasso is come up with a index of how likely you are to get a particular type of care based on the supply of providers in your area. So in a way, it's not so different than what I did a long time ago, trying to predict probability of insurance, and then using predicted probability of insurance. I just have a fancier way of doing the prediction of what kind of treatment that you get.
It's really my concern is whether those same variables might also have an independent effect on your outcomes. You're assuming that this whole bunch of supplies, provider characteristics locally and so on, only influence your outcome variables through your treatment variable. And it's that concern. So I'm not at all worried about your first stage. I think that sounds very plausible. It's the exclusion restriction. It's the assumption that those geographic provider characteristics locally and all that stuff have no independent effect on your outcome variables. And I'm not thinking that they do or don't. I can't see the argument.
I should say that we're controlling in everything with zip code fixed effects. So something like something that might be correlated with whether there were a lot of psychiatrists in your area is like, are there a lot of hospitals in your area, right? But hospitals don't change very much over time, and the psychiatrists do change quite a bit. So, or at a higher frequency anyway. So the purpose of the fixed effect, and we're only looking over 6 years, right, is to control for those kind of characteristics of the area, and then use variations in the supply within that relatively small area as the identifying variation.
There's another question from Margit Reicher. I don't know how Christopher and Julius want to handle that, whether to put her as a panelist or just give it the audio, or otherwise I can just read the question for her. Christopher?
So I think I got unmuted now. I don't know if people can hear me. So okay, great. So thank you, Janet, for your really interesting presentation today, and I learned a lot. I was wondering actually how important peer effects are when we want to think about improving or treating mental health in kids. So what I mean by peer effects is like, in school, for instance, in your class, actually, if you have any, my school friends are actually, I don't know, getting treated on certain illnesses, that all of a sudden, I might be also more likely to come forward, or parents are, thinking of also of treatment options. I think that's one side. And the other thing is when, in a certain area, I think what we saw is that's very clustered geographically. That's, for instance, also there's a network of psychiatrists who are talking to each other, so that it's very likely to focus just on one type of treatment rather than exploring also different options. So I was wondering if how important these peer effects essentially are, and there must be ways of measuring those actually in the data, also from an empirical point of view.
Well, perhaps. Actually, it's interesting because you raised two different kinds of peer effects, right? Peer effects among the children and peer effects among the providers. So one thing that, so I have looked a little bit at peer effects among the providers, and there is this whole peer effects literature in health economics about spillovers in care from one type of provider to another type of provider. And it's kind of inconsistent because some people find big spillover effects and some people don't find big spillover effects. And so my characterization of that is it may depend on how much interaction you're likely to have with other providers of your specialty. So for example, like heart attack, heart surgeons apparently have a lot of spillovers. And when you think about that, it may be that, well, they all have to work in a hospital. They all have to work with like specialized teams of nurses. So there's kind of a mechanism for there to be transmission. A lot of psychiatrists, on the other hand, work by themselves. And so they don't talk maybe to other psychiatrists as much. And for psychiatrists, I haven't found a lot of evidence of spillovers. So, you know, I showed you these area level measures. If you look within areas, you see as much variation as across areas. So that's a sort of indicator that a lot of this is just coming from variation in what individuals are doing.
But it should, like the interaction, let's say, would you expect that to have like a positive effect actually on treatment and actually improving mental health in kids? So if we would allow more for discussions, well, not of patients obviously, but of treatment options or exploring different alternatives.
Well, I think it could go either way, right? So depending on, people could converge on a bad equilibrium as well as on a good equilibrium. And so one of the problems with psychiatry is that it is pretty hard to judge what the outcome is going to be. There's a lot of very inconclusive clinical trials. You kind of need to look at a lot of people to be able to see whether one treatment is better than another, because there's a lot of idiosyncratic variation. I think it's less easy than some other things to know what the right thing is to do.
Thank you for clarifying.
So there are two more questions coming right up, and if anybody has something urgent, please put it in the Q&A now, because then at some point we're going to have to draw this to a close. There's Rachel Feldman and then Anvita Mahajan. Again, whoever is pulling the strings behind the curtain here should put them on.
Okay, hi, I think I'm unmuted. So I guess my question is, like, you mentioned that the increase in cases or diagnoses might have been seen as an overall worsening of mental health in children, but that you argue that it might just be due to more screening, which I guess I would tend to agree with. But my question is, like, can we test this in any way? So, like, if these cases would be there anyway, and we're just identifying them now, right? So, like, identifying them and treating them should help with overall outcomes, right? So I'm guessing my question is, even though treatment might vary wildly, my prior would be that, you know, treatment is at least weekly increasing with these diagnoses, right? More kids might be in therapy or receiving these non-red flag drugs than, you know, with fewer screenings. So can we test to see if this is working? Like, are children missing fewer days of school, or is, you know, there's some outcome there that can show that maybe children's health isn't worsening, just, you know, being exposed?
Right. I think those are great questions. Like, what I can look at in the claims data is only the medical outcomes. So I don't actually know whether they are missing less school or whether they're going to graduate from high school. And in fact, in the claims data that I have, since it's only 6 years long, I can't even follow them up for very long, right? I can't say, well, in 10 years, what was the impact on their overall healthcare costs? So I guess what I'm trying to do is show that there is all this variation, that it does seem to be linked to at least this set of short-term outcomes. And so therefore it might have effects over the longer term, and that it would be a good thing for somebody to look at. So I understand there's lots of graduate students in the audience, and so I'm kind of making a pitch for that. This is a really interesting thing to work on.
Sure, thank you.
In fact, Rachel is a graduate student, and then the next question is also from a graduate student, Anwita Mahajan.
Thank you. Thanks, Professor Curry. My question was a little bit more general. Are there data or work on the channel through which mental health affects labor market outcomes? In the sense that, is it that people are missing work days, or are they less productive at work when they're there? And if it's the former, is there data on whether employees are reporting as sick and using paid leave? What's going on there?
So there's actually an OECD report that talks about the cost of mental health on labor markets. And so they basically say there's some of both. So there is a lot more missed work due to mental health problems. And then people, when they're at work, are also less productive. Now, I don't know, sort of getting further than that and saying, well, are they using their sick days or things like that? I don't know. But both of mechanisms are important. The number of days lost is large, and the wage effects are also large. So.
Right, and just to follow up, when there are days lost, is there any information whether the employees are reporting that the days were lost because of a mental health issue rather than just a general sick leave?
So there is some old data available from the Department of Labor that is based on a survey of employers where they were asking whether, what the cause was. And so an interesting thing was that if people lost days due to a mental health problem, they were much more likely to be out for 30 days or more than if it was for a physical health problem. And that actually makes a lot of sense, because if you think, like, even cancer treatment, somebody might miss a day of work when they have chemo, but they're not going to be out for 30 days because of that. Or surgeries, most surgeries now, people can be back, maybe in a week even. So people, when they lose work, are more likely to have these really long spells out of work because of mental health problems.
Thank you.
And I have one, I think, last question from Marianne Bronson. We would have time for maybe one more after this, but then I think we need to close.
Hi, Janet. Thank you. That was a really, really interesting talk. My question is about not so much the child mental health aspect of this, but the rules versus discretion aspect of this, which I guess is a question more broadly about how treatment is prescribed. So I'm wondering, I guess the trade-off between rules versus discretion is that discretion could potentially be good if doctors have more flexibility to tailor treatments. But I guess in your data, probably there's a way of understanding whether doctors are not really using discretion, but just applying the wrong rules. So that some doctors are just systematically prescribing red flag drugs. It's not that they're really using discretion, because they're not applying personalized treatments to different people as they see fit, but they're just systematically applying the wrong rule. So that's the first part of my question. And then the second one is that kind of related, but a different flavor of that, which is that perhaps discretion is also misapplied. So if doctors systematically prescribe a certain type of treatment to people based on their race, again, that's not really perhaps discretion, but maybe again a misapplication of a rule, thinking maybe based on discrimination, thinking how likely patients would adhere to a certain treatment regime, et cetera. So I'm wondering whether it's something you've looked at in your data, and whether you can.
So one of the things that I have looked at, though I haven't done it for this sample yet, but I've looked at in some other data, is just the variance in the doctor's prescribing. So it turns out that most doctors, in actually most specialties, have a favorite drug for, a particular condition. And they're not all the same favorite drugs. So if I'm a psychiatrist and I'm treating depression, maybe my favorite drug is Zoloft, so I give everybody Zoloft. And somebody else's favorite drug is Lexapro, they give everybody Lexapro. And so a lot of prescribing kind of falls into that favorite drug category. So somebody who is actually, it would be sort of a crude measure, but somebody who's trying to tailor drug treatments to a particular person, you should see them using more drugs. They should be using a broader portfolio of drugs than somebody who's just prescribing the same thing all the time. You do see, on average, like psychiatrists use a broader portfolio of drugs than primary care physicians. Primary care physicians are so half of the mental health prescribing in the US is by primary care physicians, and they're much more likely to just have one drug and stick to it for everything that they're treating in the mental health category. So I do think it's possible to look at that. And then in terms of how you could tell if somebody was discriminating, that is also a great question. In one weakness of claims data is that it doesn't usually record people's race, because if you think about it, it's a bill, right? What relevance does it have to your bill, what color you are? So what you could do is you could try and impute race based on, say, where somebody lived. If somebody was in a heavily African-American zip code, maybe they were more likely to be African-American. So you could try and look at things like that. But then what you'd need is a doctor who's treating people, say, in white zip codes and African-American zip codes, and see if the same doctor prescribed differently to different people from different areas. So that would be doable. It's a good idea.
Thank you.
I don't see any questions, further questions coming in. This is the point where I sort of say, oh, you can try and grab the speaker afterwards if you have any more questions. Of course, you cannot do that. So it feels tougher to say that we're coming to a close. But Janet, thank you very, very, very much for a very interesting, engaging lecture. And I think we go to the second part of the proceedings. This is where I normally have, whoever presides has a certificate. We try to make a PDF one, which we share it on the screen at some point, and then the recipient also gets a check. The check should be able to produce it by ACH transfer, as we normally do. Oh, there it is. So the recipient of the prize, thank you, Julius, is Francisco Garrido, and this is part of his dissertation, and this is the prize for the best paper by a graduate student. Everybody can read the title. It's very long, and it's mergers between multi-product firms with endogenous variety theory and an application to the RTE cereal industry. And the advisors are John Rust and Nate Miller, who are both on the panel. So perhaps they can, I don't know whether we can have, it would be nice to have Francisco, Nate, and John, but if it's just one, has to be just one. It's Francisco, who now gets the mic to say thank you to whoever he wishes to thank. Congratulations, Francisco, and the floor is yours.
Okay, thank you, Luca, for your introduction. And first of all, I wanted to thank Janet for this very interesting lecture. I would like to thank the Razin family for generously sponsoring the Razin Prize every year, and tell them that it's truly an honor for me to have my work recognized by the academic community in the economics department. And so thank you very much for making that possible. So typically people speak a little bit about the research, but I think that since I feel like we're a little bit pressed of time, so I'm just gonna skip that part and point you to my webpage in case that you're interested in learning about the cereal industry. And I just wanted to thank Nate Miller, John Rust, and Roger Lagunoff, who were my committee. I want to thank them for always being available to discuss my ideas, even the not very good ones, and for taking the time and the effort to review my work, which I know must have been painful, for giving me insightful comments and feedback, and especially for having my back throughout the job market process. Going through the job market, as most of you know, it's a very demanding experience, and it was a big source of comfort for me to feel like you guys had my back and you had confidence in the quality of my work. I'd also like to thank my wife, Lizzie, who's here with me now. I want to thank you for agreeing to come to DC with me and for putting up with the hardship that grad student life imposes. And especially I wanted to thank you for the emotional support that you gave me throughout the past 6 years. Grad school comes with many emotionally challenging times, and I can't imagine how hard they would have been if you hadn't been with me. Thank you. And I would also like to thank my parents who are actually listening from another room here in the apartment. And finally, I would like to thank the community of the Economics Department, the faculty, my former fellow grad students, and the administrative staff. I truly feel very fortunate to have had the opportunity to share this past 6 years with all of you. And I am very sad that we did not get to say goodbye properly. So I'm sure that I'll be back in Georgetown sometime soon and I will get to do it right. Thank you very much.
Thank you, Francisco. These are touching words. Sorry, I'm doing something. These are touching words, and they highlight a very special, among other things, a very special situation we're all living through. I don't know whether, and I'll miss you as TA, by the way. I mean, I've never worked with you, but I suddenly remember you as my TA, doing an excellent job. I see that John and Nate are both there. I'm not sure if they want to say. Roger, I don't think is around. I don't know if John or Nate want the famous last word today. Otherwise, we are.
Well, let me just say I'm very, very happy that you got the award, Francisco. And like so many great students I've been advising at Georgetown, I just feel lucky that they picked me. And I think I learned more from them than I feel like I gave to them. But in this case, I'd like to hand it over to Nate, because Nate really gave some really good suggestions that really helped Francisco. And Nate and I co-taught an IO course, and Nate's been very influential for a number of other grad students in our program. So I'll turn it over to Nate for the last word.
Sure. Hope you all can hear here. Francisco did not describe his work much, so maybe I'll just give you a sense for why I think it's really nice. You know, I've got a lot of background in antitrust and in the field of industrial organization, and there's a lot of open questions there. And Francisco just walked into my office one day and said, "Look, I want to explore mergers, and in particular whether mergers between two firms, two competitors that might create higher prices or a loss of competition generate sort of dynamic effects in the market that encourage entry, or how should we think about the longer term dynamic implications of mergers that otherwise would be anti-competitive?" And he applied some new modeling techniques that took a lot of energy and thoughtfulness to figure out. And he did that all on his own, and he kept on coming up with new results. And he ended up with a paper that I think is not only methodologically really rigorous, but is going to be helpful for the antitrust authorities in the US and elsewhere. Think through anti-competitive mergers and some of the dynamic effects that come through come with it. So just a really nice combination of theoretical insight, doggedness, chasing down some difficult models, and an application to the ready-to-eat cereal, which actually in our field we know a fair bit about. We turn to it often, and so I really applaud Francisco. I think the award is well deserved and quite an important contribution. So congratulations again to you, Francisco.
Thank you very much.
So I guess it's one very last thank you to everybody and everybody who has helped organize this, even behind the scenes. And a very big thank you again to Janet, and congratulations again to Francisco and his two advisors. And I think after maybe asking once more permission from everybody, we could be maybe posting this link to this recording on the Racine Prize web page. Perhaps Janet may want to review before we actually go ahead with that, but I expect that we should be able to do that relatively soon. And thanks everyone again, and I declare the proceedings closed. Usually there's a clap. I'll be the only one unmuted who does it. Janet, thank you very much again.
Thank you.